This is week 3 in your advanced pathophysiology course, and the topic this week is neoplasia. I have loaded for you on Blackboard 3 items which I think are important. One is a 41-minute audio lecture specifically on neoplasia. The second is a slide deck of about 90 slides that will walk you through your textbook. And the third is a TED Talk, and the woman is phenomenal and talks about thinking out of the box and new treatment modalities in cancer treatment. So I highly recommend you watch this. My goal, of course, is to try to link all the pieces together and to give you real-life examples of work so that you will better be able to understand. When we start our study with week 1 talking about cellular death and the structure of the cell, while we move on to the genetic structure and disorders that occur with DNA, before we move in to any of the body systems or any of the other disease processes. So neoplasia is a good place to start, and it's a good place to start because it gives us a very clear understanding of apoptosis and necrosis and what happens, as well as the genetic damage that occurs and the damage that occurs to the DNA, especially with radiation injuries. And so it allows us to see the bigger picture of why we study cell death first and genetics second before we move on, and why it's so critically important to really learn these 2 areas cold. You need to know them inside out. Cellular death occurs as a result of apoptosis and necrosis, or when cells are no longer able to maintain homeostasis. While apoptosis is reversible, necrosis is not. Radiation can result in both. Radiation can affect the body in a number of ways and have harmful health consequences that may not be seen for many years. Effects are dependent on the type of radiation, the route of exposure, the length of time a person is exposed, and the amount of radiation absorbed by the body. Effects can be mild, such as reddening of the skin, or serious as cancer or even death. There are both short and long-term effects of radiation, which can increase the risk of cancer. If a reasonable dose estimate can be made, a lot is known about the health effects of the dose. Our hospitals, military, and public depend on the use of radioactive materials for electricity, medical diagnosis and treatment, research, manufacturing processes, and munitions. The widespread use of radioactive materials brings with it equally widespread possibility of accidental and intentional exposure. The materials can be used to create a radioactive dispersal device, but the greater concern is one of accidental inhalation, ingestion, or absorption through a wound. DNA is the key factor in the biologic effects of ionizing radiation. Radiation induces DNA damage by reactive oxygen species that we refer to as ROS, resulting from the ionization of water. This is similar to ROS damage from a normal aerobic metabolism. There are some repair mechanisms for DNA damage if the damage results from a single-strand break, or in some cases, a double-strand break. Repair is a double-strand break. Repair can occur through the enzymatic steps of a polynucleotide ligase. If the radiation damage is too severe and the DNA is not repairable, then reproductive cellular death occurs. If the DNA is misrepaired and the cell survives, it will result in malignant diseases such as carcinogenesis. The simplest effect of ionizing radiation has on the cell is apoptosis. Non-lethal changes that occur at lower doses include delayed mitosis, causing changes in cell kinetic patterns, disruption of cell growth, increased or decreased permeability resulting from a change in the lipid bilayers, resulting in a loss of metabolic equilibrium, decreased cell motility. It follows that the cells most sensitive to radiation are those that are actively proliferating. For example, hemocytoblasts and lymphocytes are very sensitive to radiation. Likewise, the cells that are most radioresistant are those that are not normally dividing as frequently or not dividing at all, such as striated muscle cells. Skeletal muscle is listed among the cells that are the least radiosensitive. Despite the fact that skeletal muscle is less radiosensitive than most cells, there is evidence that it is impacted. It has been shown that muscle can be exposed to low doses of ionizing radiation, loses the ability to generate passive and active tension in response to stretch and calcium. The loss of the stretch is believed to be the result of the depletion of titin and nebulin. Now, just a quick review. Remember, last week I showed you one table of apoptosis and necrosis, and this week I'm showing you another. And I'm repeating it because it's important. At the very basis of what you learn about the body, you need to understand the cellular level and how cells live and die and what the difference is between these two processes. Remember, apoptosis, the cell shrinks and the DNA is degraded and fragmented, and it's all carried away safely when it's working as it should. In necrosis, the cells swell, they explode, and when they do, they release their enzymatic contents, and that impacts all the neighboring cells. Not to mention there are specific stimuli that result in apoptosis and necrosis. And you can see from the list here that there are some similarities, but there are differences. So you need to know that the type of illness that would result from necrosis is not the same things that you're likely to see with apoptosis. Remember, go back and study this. If it's slipping from your memory, you need to go back and review it again. Carcinogenesis can develop in any tissue at any time and is a complex biological process that is best viewed as a system. Armitage and Dahl proposed a classic theory of cancer that is considered foundational. Within the tissue, there are a number of cells that can divide and potentially experience a carcinogenic transformation. At some point, the 10th or the 100th or the millionth change, which is sudden and irreversible, it results in the development of cancer. The multistage model of cancer cancer serves as a foundation for hypothesis formation and the design of experiments, especially in determining dose, age, and timing of administration of the suspected carcinogenic agent. The agent may serve as only one step in the transformation of cells. The stages of carcinogenesis can be broken down into 3 stages: initiation, promotion, and progression, with each stage potentially having multiple genetic changes. Initiation begins the process by the irreversible alteration of cells. Promotion occurs when the altered cells expand to become a visible tumor. Progression is considered the time when tumors move from benign to malignant. The process can be used to explain how a non-carcinogenic agent can influence the carcinogenic process, such as is the case with exposure to radiation or to embedded fragments that may be radioactive or others. Now, What I want to show you here is one of the things that people look for when they're deciding, did we get all the margins of a tumor, is they're looking for, or is it malignant? And what they're looking for is mitotic figures, which are frequently present in cancer. And what I have here is yellow arrows that are pointing to two cells that are in mitosis. This one is maybe late mitosis, and this one's not in mitosis at all. Excuse me. And what you're doing is you're counting the number of these in 10 consecutive high-powered fields closest to the tumor. Again, here's another picture. Mitotic figures can be counted near the site. And in this case, this was my doctoral dissertation on on histologic changes in rats that were implanted with heavy metals. And what we were looking for is changes that occur before the full development of cancer in the muscle. And so we were looking for mitotic changes, among other things. But at any rate, mitotic activity was one of the things that we were looking for in these. And while if you blew up these pictures, you could look and find the mitotic figures. If you look here, this is a much smaller magnification, and it shows you our control, which is known not to cause cancer. In fact, this metal tantalum is frequently used in prostheses against the heavy metal tungsten alloy, and you can see them side by side and tell the difference. But this is what we were looking for, changes that might occur prior to the development of cancer. I wanted to show you this slide because it is significant in that it shows you necrosis. The incidence of tumor necrosis was determined through histologic examination of cross-sections of the tumor. Generally, tumors with greater than 20% area are considered positive for tumor necrosis. So, some of these were positive controls, negative controls. So you can see in this one, this is perfectly normal. This is our control. Nothing's going on. But you can look here and you can see the cells that are swelling and becoming round. And this is basically an indication of necrosis. And what you're looking for is 20% of the cells necrotic. So you're literally going through and counting the ones of these that are beginning to swell. Now you also have apoptotic bodies in here. So the black arrow is pointing to an area here where you have an apoptotic body. One of the things that you can do is you can blow these cells up and the sides up, and you can actually see this much better. But these were in a study that we were looking at shrapnel injuries in rats. So we implanted them with metals that you find in military munitions. And the dose that was implanted with them would be the equivalent of the average dose that you would expect in a soldier with a war injury. More pictures of the same thing. Our goal was to show that the newer metals, the tungsten alloy, was safer than what had previously been used depleted uranium. Much to our surprise, it turned out not to be the case. But this is a histologic section of the gastrocnemius muscle implanted with the metals. And then we stained them, and we looked at them 1 month post-implantation, and then at 6 months. And we were looking for collagen formation and infiltrates in the spaces between the myofibers. And this was one of the things we wanted to look at, was early collagen formation, a sign that the rats were going to develop carcinogenesis. So you can see here fairly normal cells, and you can see the ones that this is tumor, and you can see what happens when they start getting disrupted. So this is the area around the embedded fragment where we had pulled it out, and this is the muscle changes. You can see this is not looking like this, nor any of the rest of them. And then this is just side by side, 1, 3, and 6 months. The top line is our control, our negative control, so we didn't expect these to have any changes, and you'll notice they basically don't. And this is our low dose, and this is our high dose, and you can see what happens to the high dose of the metal. The tumor is just becoming invasive, the collagen is taking over, and there are lots of changes that are occurring, and lots of fibrotic changes. So to bring you back to this, because there is a correlation between the number of mitotic figures and the biologic behavior of tumor, the number of mitotic figures was counted in 10 consecutive high-powered fields. And we counted those closest to the area of the metal. So again, you're looking for mitosis. So let's go back and remember, we're looking for the difference in necrotic bodies and apoptotic bodies. So if we're looking for apoptosis, one of the things we're looking for is the number of cells that are actively in mitosis. I hope you're beginning to see the linkages between cell life, death, and what impacts our bodies. Always look back to the cellular level when studying pathophysiology, and remember that what impacts the cells will impact our whole body.